Welcome to the latest installment of the AST Journal Club series. Today's featured AJT Journal Club session is on a multi-institutional study of renal outcomes and renal-related pregnancy outcomes in uterus transplant recipients. This session is sponsored by AST's Vascular Composite Allotransplant Advisory Council. In a moment, I will turn our session over to our moderator, Dr. Monika Sarkar from the University of California, San Francisco. But before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. This Journal Club is being recorded, and the archive will be available on the MyAST website in 2 to 3 business days. Finally, when you log off at the conclusion of today's Journal Club, you will see a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn our session over to Dr. Sarkar to begin the presentation.
Thank you, Brian. So my name is Monika Sarkar. I'm a transplant hepatologist at UCSF and chair-elect of the Women's Health Community of Practice. And it is with the greatest pleasure that I introduce our speaker, Dr. Deirdre Sawinski, to discuss her work on renal outcomes during pregnancy in uterus transplant recipients. So a little bit about Dr. Sawinski. She's a transplant nephrologist and associate professor of medicine at the Weill Cornell Medical Center. And she's also the associate director of their kidney transplant program. Our clinical research program is focused on outcomes for kidney transplant recipients, with a special interest in the impact of chronic viral infections. She's also a very productive scholar. Dr. Sawinski has 3 active NIH grants and has published over 90 peer-reviewed manuscripts. So today she'll walk us through a highly novel topic of pregnancies after uterus transplant and share her team's multi-centered data on renal-related outcomes in this growing population. So take it away, Deirdre.
Thanks a lot, Dr. Sarkar, and thank you to the VCA Advisory Council for suggesting this topic and me as your speaker. So here's our conflicts of interest. I personally have no financial relationships relevant to this presentation to disclose. And here you also see the disclosures for our moderator, Dr. Sarkar. So uterus transplantation has been available since 2011 as a treatment option for uterine factor infertility. And it actually represents a rather unique treatment paradigm if you think about it. Unlike all other transplant scenarios that we encounter, you are taking a cohort of healthy women, giving them a temporary transplant, putting them on immunosuppression, and after childbearing is completed, removing the transplant and stopping immunosuppression, supposedly with no ill effects. And here you can see the process by which uterus transplant recipients move through the different stages. They're all evaluated and screened in a process that mimics what we do for our usual transplant recipients. They are required to successfully complete IVF and have embryos available. They then have their transplant, which can come from a living or deceased donor, start immunosuppression, and after a period of stability, undergo embryo transfer, hopefully culminating in a successful pregnancy. All deliveries are via C-section, and either at that time, recipients can undergo hysterectomy if childbearing is complete, or retain their uteri for a second or potentially even third pregnancy, and then ideally move through to long-term follow-up. In this smaller figure over here on the right, you can see the global presence of uterus transplantation. It's still a small and nascent field. Approximately 50 or so recipients globally, with most of them being either in Europe or the United States having some of the largest uterus transplant programs. Most recipients to date have a condition called Mayer-Rokitansky-Kuster-Hauser syndrome. There's MRKH, type 1 and type 2. And it's, while its genetics are incompletely understood, it's notable for a congenitally absent or underdeveloped uterus with varying degrees of vaginal aplasia. And in MRKH type 2, about 30 to 50% of patients will also have some renal anomalies. And this is because the intermediate mesoderm is the common embryonic source for both the kidney as well as the genital urinary tract. So patients who have MRKH type 2 can either have unilateral renal aplasia, dysplasia, hypoplasia, or ectopic kidneys. And even if they have two normal appearing kidneys, can have a reduced number of normal nephrons or disorganization of the nephrons they have. They may have maldifferentiation of epithelial cells, reflux, hypertrophy, recurrent UTI, stones, and obstruction. So the women who are coming to uterus transplantation to be considered are at increased risk for having renal abnormalities that may or may not be evident at the time of evaluation. And this is relevant because we know that kidney function has implications for pregnancy outcomes. And I show you data here from a global meta-analysis that looked at the rates of preeclampsia, which is a very important complication of pregnancy, among kidney transplant recipients. And while you see that in the red line indicated here at approximately 5 to 8% being the US average rates of preeclampsia, kidney transplant recipients across the globe have a rate of somewhere between 25 to 30%, so significantly higher. We also see in this data over here, looking at two separate cohorts of chronic kidney disease patients, that as you have progressive increase in your chronic kidney disease stage, the likelihood of you having pregnancy complications, whether that's preeclampsia or preterm delivery, complications for your baby, increase. And importantly, having a higher or more advanced stage of chronic kidney disease at the time of conception increases your risk of accelerated renal decline in the postpartum period. So having abnormal kidney function can impact your pregnancy outcomes and your future renal history. So the aims of our study were to try to understand the renal outcomes for uterus transplant recipients and to explore the relationship between changes in renal function and their pregnancy outcomes. So to do this, we acquired data from 3 institutions, Baylor, the University of Pennsylvania, and the Institute for Clinical and Experimental Medicine, or ICHEM, in Prague. Candidate evaluations were at the discretion of the local center, and this was all retrospective data, so we had to work with what was done. All centers did engage in some sort of renal imaging, but that varied: ultrasound, CT, MRI, and all centers required candidates to have successfully created embryos via IVF before enrolling. In terms of immunosuppression, all 3 centers used rabbit antithymocyte globulin induction, and immunosuppression followed kidney transplant standards in that tacrolimus with mycophenolate mofetil with or without steroids was the mainstay. In preparation for embryo transfer, mycophenolate was changed to azathioprine, and the target tacrolimus levels were somewhere in the 6 to 10 nanograms per ml range. Patients underwent cervical biopsies to monitor for graft rejection. And a single embryo was transferred at 6 months. All patients were started on aspirin for preeclampsia prophylaxis. All deliveries were by C-section, and most patients went on to have a graft hysterectomy shortly after delivery. And in terms of our analysis, eGFR was calculated using the 2021 CKD Epub formula, and definitions of acute kidney injury were using Aiken criteria. So here's the results. So our cohort of patients had a transplant from 2016 through 2020. So 18 women, and we only included women at all 3 centers who had had a successful pregnancy. So more transplants had been performed, but they either had not delivered or yet gotten pregnant. So at the time of our analysis, we grouped our patients into those who had preeclampsia, which was 5, compared to those who did not, 13. And we see that overall, our patients were relatively young. The cohort was overwhelmingly Caucasian. Almost all of them had MRKH as the etiology of their uterine factor in infertility. Only one recipient had a solitary kidney. Most of the transplants came from living donors, and everyone had normal kidney function, whether you think about that in terms of serum creatinine or GFR at the time of evaluation and pre-transplant. We see that the rate of gestational hypertension was quite high, 30 to 40%. The rate of gestational diabetes about 20%. And not surprisingly, the preeclampsia cohort did deliver a little bit earlier than the cohort who did not have preeclampsia. And most of the patients went on, 10 of them, to have a graft hysterectomy. So here you see the change or trajectory in eGFR in our cohort over time. So as I said, everyone started out with a normal serum creatinine and a normal eGFR over 100 mLs per minute at the time of evaluation. All patients experienced a decrease within the first month after transplant, which is likely representing the institution of calcineurin inhibitor-based therapy. And GFR remained lower throughout the pre-embryo transfer, embryo transfer, and pregnancy period. This reduction in GFR actually continued until the early postpartum period. And we see that the lowest eGFR was at 3 months after uterus transplant through to delivery. And cumulatively, there was a 50% AKI rate, and this was grade 1 AKI. In the figure here on the right, you can contrast what happened in our cohort in terms of eGFR trajectory throughout pregnancy and the postpartum period, plotted against the line in orange here, which shows you the expected change in eGFR during pregnancy. So in a cohort of normal healthy women, you see that you have your starting GFR, you become pregnant, and then there's actually an increase in GFR throughout the trimesters that peaks towards the early 3rd trimester and then normalizes after delivery. Uterus transplant recipients don't experience that same compensatory increase in GFR, although they do experience that decline around the delivery period. And some degree of rebound after delivery and ostensibly graft hysterectomy. So we were interested in knowing, since preeclampsia is an obviously undesirable complication of pregnancy, was there any way to predict who was at greatest risk from the start? So here you see eGFR trajectories plotted out. And the group in blue are the women who did not experience preeclampsia, and the group in orange is the women who did experience preeclampsia. And you can see that from the very beginning, numerically, eGFRs are lower in the group that goes on to develop preeclampsia, only reaching statistical significance at the 16-week mark. But if our cohort had been larger, that difference may have been obvious sooner. And this reduction basically continues on until after delivery. We looked at different factors that might contribute, like tacrolimus levels, and found no difference in the average trough levels of tacrolimus based on whether or not uterus transplant recipients went on to develop preeclampsia. We also looked at whether or not there was a difference between the timing of embryo transfer, and there was no significant difference, 207 days versus 203 days, in terms of time from transplant to embryo transfer on the basis of preeclampsia status. The obvious question is also whether or not renal function improves after hysterectomy. So as I stated earlier, 10 out of 18 women in the cohort at the time of this publication had had a hysterectomy. And not surprisingly, GFR was lower in those who went on to have a hysterectomy compared to those who retained their uterus for second attempts at pregnancy. And what we did found when we stratified the groups by hysterectomy status and by presence or absence of preeclampsia was that there were some differences where women who had preeclampsia and then had a hysterectomy had a significantly lower GFR at time of delivery, probably retrospectively impacting that decision. And women who retained their uteri and did not have hysterectomy or preeclampsia actually had some of the best renal function, returning to near normal by 3 months after after delivery. So it's obviously a small cohort, but this is still the first study that's dedicated to looking specifically at renal outcomes among a rather unique group of transplant recipients. As I said, given that there's approximately 50 or so women with uterus transplants worldwide, it qualifies as a relatively large cohort and international in its scope. Because this was center-based data, we were able to look at TAC troughs and granular changes in creatinine. Unfortunately, we didn't have measured GFR in our cohort. We unfortunately also did not have consistent collection of proteinuria data, which certainly would have been interesting to examine. And as I alluded to earlier, each center had their own specific protocols in terms of candidate evaluation, whether or not they would accept individuals with solitary kidney, how did they assess kidney function going into transplant. Immunosuppression protocols did vary a little bit. And again, this cohort is predominantly women with MRKH. So what are the implications of this data for uterus transplant recipients and their care more globally? So one of the questions that our first study couldn't answer is what really happens after hysterectomy and is renal function recovered? Since this had always been the working hypothesis that when you would take the uterus transplant out, stop immunosuppression, everything should go back to normal. So we actually did a follow-up study with a slightly larger cohort of 22 women from 4 centers, 3 in the US, and again, the center from Prague. And we used mixed methods to map out GFR slope over time. And this data here shows you a median of 3 years of follow-up with a median of 2 years of time off immunosuppression. And what we see here is, so the 0 line is the starting eGFR, so pre-uterus transplant. And again, as we saw previously, everyone has a decline after the transplant and immunosuppression is started. There's embryo transfer, you get a dip with a small increase, and then a nadir at the time of delivery. Then immunosuppression is stopped, and while women do have a rise in their GFR over time, even at 12 months of follow-up, the eGFR is still lower than the starting eGFR. And we actually quantified that difference. It's on average about 10 mLs per minute lower. We looked at factors that might have influenced this. None of them were statistically significant, but there was a trend towards having episodes of acute kidney injury, preeclampsia, and longer exposure to immunosuppression, all being associated with lower eGFR after withdrawal of immunosuppression and hysterectomy. And to put this change of 10 mLs per minute in context, normal aging, you would expect a decline in GFR of anywhere from 0.3 to 1 mL per minute per year. And in patients who have a rapidly progressing glomerular disease, we talk about a change of maybe 3 mLs to 5 mLs per year. So this certainly is not only statistically, but clinically significant. Then in terms of longer term healthcare, and this is data from the general population, we see that having preeclampsia increases your risk of chronic kidney disease in the long term by about 2-fold, end-stage kidney disease about 5-fold, and even gestational hypertension, which is often thought about as being a more benign condition, still increases the risk of chronic kidney disease and end-stage kidney disease significantly. And in these two graphs here, you can see a plot of your all-cause and cardiovascular related mortality against GFR. And as your GFR declines, moving to the left of the graph, you see that your risk of all-cause mortality as well as cardiovascular related mortality increases. So losing 10 mLs per minute is not insignificant when you have an entire lifetime ahead of you. So what about patient selection? As I've said, almost all of the women who were transplanted in our original two studies had MRKH, and we know that they have reasons to be at increased risk for kidney damage or kidney functional compromise. And so while this is common, this is data from SRTR, it's not necessarily the future. If you look in this survey here, the largest growing interest in uterus transplantation is actually among women who have a surgically absent uterus. So perhaps this trend may be different or reversed in a cohort of patients who are less likely to have unrecognized underlying renal dysfunction. There's also things that we could be doing from an immunosuppression perspective. Obviously, it makes sense to try to minimize any given patient's exposure to tacrolimus. So that does mean rethinking the time to embryo transfer. Historically, it's been 6 months, but is that needed? Would 3 months be okay? Discussing with the patient the total number of attempts, the number of embryo transfers that would be allowed, since unsuccessful attempts obviously increase the duration of PAC exposure. What's the interval between pregnancies? So, from an obstetric perspective, you may want to wait at least a year or 18 months, but from a kidney function and immunosuppression exposure perspective, that may not be desirable. And in terms of the timing of hysterectomy and immunosuppression withdrawal, it does seem that that should be done as close to delivery or potentially concurrent if possible. And then there's the question of what tacrolimus trough levels we should be targeting. So when we measure tacrolimus levels, we're measuring in clinical practice whole blood levels. And there's only a small proportion of TAC that's free. Most of it is bound to either hemoglobin or albumin in the serum, and that's what's being measured. But we think it's actually this free or unbound tacrolimus that's causing a lot of the toxicity. So we've used this paradigm where we dose tacrolimus for uterus transplant recipients as if they're kidney transplant recipients. But we know that pregnancy has an impact on tacrolimus levels. You have an upregulation of CYP3A4, which is the main metabolic pathway in the liver. You also see, as I showed you earlier, expected increases in GFR. As you move through the trimesters of pregnancy, total body water increases. So this means that there's a dilution or a relative decrease in your serum albumin and your hematocrit. So while we do adjust our TAC levels throughout pregnancy to keep the whole blood troughs the same, and this is data shown here from a cohort of kidney transplant recipients, and you see from early pregnancy throughout the trimesters that whole blood levels remain the same as we increase the doses. But actually, over time, the free TAC increases. So you see that by the 3rd trimester, it's reaching a peak because there is more unbound TAC in circulation that we're not picking up on. Currently, free TAC levels are not clinically available, and there is no accepted formula to estimate or convert to those levels. So this is definitely an open area of investigation that needs to be resolved, not only for uterus transplant recipients, but for any solid organ transplant recipient who desires pregnancy. One might also wonder, are there alternatives to tacrolimus? So mTOR inhibitors do exist, but unfortunately, they are associated with some of the same teratogenicity as mycophenolate products, were not recommended in pregnancy. And belatacept seems like a very attractive option. It is not nephrotoxic. It doesn't have the same vasoconstriction as calcineurin inhibitors, but there's really very limited data. The package insert says that based on animal data, it may cause fetal harm, but the 2 animal studies that are cited in the package insert actually don't report any fetal effects. There is one small study from the Transplant Pregnancy Registry International that had 12 kidney transplant recipients who had 16 pregnancies and 13 live births with no reported birth defects or fetal deaths. So obviously this is very limited data suggesting it might be safe. But this, renal benefit has to be balanced against the increased risk of rejection that's known in the kidney transplant literature, and specifically cell-based rejections, which are what are more common among uterus transplant recipients. So this might be better from a nephroprotective perspective, but not good for maintaining your uterus graft overall. Additional considerations, you have to dose belatacept based on weight, so this would need to be adjusted over time throughout the gestational stages, and certainly merits further study and discussion before it could be implemented as a standard immunosuppression in this population. So what about counseling and surveillance? So certainly, I think discussion of the potential renal complications should be included in informed consents for all uterus transplant recipients, and should be incorporated in shared decision-making surrounding a potential second pregnancy for women who have a first delivery. There also needs to be a uniform plan for long-term follow-up. So currently, in the United States standard of care, we usually only follow recipients for 1 to 3 years. This may be a place where the International Society of Uterus Transplant Registry could step in. I know in Prague, the Czech Republic, they actually mandate lifelong follow-up for these individuals, which seems appropriate to discover long-term side effects we may not know about. And this is something the community needs to think about as we move from the research to more standard of care setting for uterus transplant, and as individuals are traveling from abroad to the US to seek care. And certainly it does seem like engagement with your specialist, whether that's nephrology and cardiology, would be beneficial not only during the pregnancy, but also in terms of the long-term care, since the increased cardiovascular side effects and kidney disease seen in those who have preeclampsia. So I hope I've shown you our data from the small study, but still I like to think a provocative one, that is uterus transplantation is associated with an increased risk of preeclampsia. Importantly, that renal recovery is incomplete even after hysterectomy and immunosuppression withdrawal, and makes the case for the fact that longer-term data are needed to better inform our risk prediction and appropriate counseling of recipients. So with that, I'd be thrilled to welcome my moderator back and take any questions and have a discussion about our data.
Fantastic. Well, thank you, Deirdre. That was a really outstanding presentation. And thank you for your contribution to moving this field forward. So I think I'll start with a first question, which is that in your study, you're really reporting outcomes from that first pregnancy, first live birth after uterus transplant. But a few women were able to go on and have subsequent pregnancies. Do you have any data on that and kind of the additional potential hits of subsequent pregnancies, even longer duration of CNI exposure, and how that affects GFR trajectories? And then the second question is for those events where a pregnancy was lost, and what was the impact there on kind of change in GFR, and if we have any data on improvement in GFR kind of following pregnancy loss?
Yeah, so great question. To answer the second one first, we specifically did not include women who had embryo transfer but didn't result in a successful pregnancy. It was a decision because we wanted to specifically look at how the physiology of a completed pregnancy and the changes that you would expect would impact their kidney function, because if someone was, say, pregnant and miscarried at 12 weeks versus a little bit earlier versus later, you may not see the same physiology and the same changes, and it would be hard to compare those. But I think it's certainly an intriguing idea for a follow-up study, because I know that there are more women who have been transplanted, but haven't yet completed a successful pregnancy that we could look at. In terms of your other question, in our follow-up study that was published in KI Reports, we did look at the small cohort of women who had a second pregnancy. It was only 5 individuals, so it's even harder to draw meaningful conclusions. And I'm sure there's some selection bias in that they were deemed to be healthy enough to go on for a second pregnancy. They still had that same decrement in GFR after immunosuppression, and on average it was about that same 10 mLs per minute, but their follow-up again is not as long as the women who had only 1 pregnancy and then were followed forward.
Outstanding. We have one question coming in from Dr. Porritt. So excellent presentation. Could Dr. Sawinski elaborate a bit on the length of immunosuppression and how this contributed to the likelihood of persistent renal dysfunction after hysterectomy? I realize this was not statistically significant.
Yes, so it did seem that women who had a longer duration, either whether that was more attempts or a longer interval until they had a successful pregnancy or had a second pregnancy, had a lower GFR once they were taken off immunosuppression at the end. But again, this cohort was very small, so we don't have enough numbers yet to make any meaningful conclusions.
And then does donor age influence outcomes? Can you talk a little bit about when it's a deceased donor or a live donor? I presume these are all reproductive age women or donors. Is that the case? And then even within that, are you trying to select for the younger uterus, and does that actually influence the outcomes and the success rates of these pregnancies?
So that's an interesting question. So again, as I said, I'm a nephrologist. Perhaps that would actually be a better question to Dr. Porritt. I know that most of the individuals in our study were enrolled at Baylor, and they have a very large living donor program. So as it turned out, more than half were living donor recipients. There have been successful pregnancies with both deceased donor and living donor. I don't know if it really, impacts your live birth rate that much. I know from my limited exposure, to recipient selection that we definitely, donor selection, do want women of reproductive age, ideally who've had a successful pregnancy, but not like a hysterectomy in the past, a C-section in the past. So you would want someone who would be a, otherwise childbearing potential.
Yeah, absolutely. That makes sense. And then it seems like it's pretty protocolized that the pregnancies are going to occur by C-section.
Yes.
And I'm wondering why that needed to be the case and kind of subjecting them to another operation, particularly for those candidates who are interested in a second or third pregnancy and so want to maintain their uterus in place for months, years to come.
Yeah, so I think it has to do with the surgery itself and whether or not, I don't know that they would think that they could have a normal vaginal delivery. I see that actually Dr. O'Neill, who's one of the OBGYNs who was involved with the project, is actually on the chat. Hello, Dr. O'Neill. So I think it's for obstetric reasons that they end up doing C-sections. I don't know of anyone who's had more than 2 pregnancies, because again, there was concern if you have multiple C-sections, but that I don't know that means that they wouldn't consider that for a really motivated recipient.
Yeah. And then just the reality of getting our patients to be able to access this incredible resource. I'm just curious how insurance is handled. Has it been, especially for patients who have MRKH and a clear diagnosis pathway, if you've encountered or had colleagues who've encountered difficulty in actually getting a uterus transplant covered?
So most of the ones that have been done in the US were done under the auspices of a research study. And so there wasn't, significant cost to the participants. I know that some centers have started doing them in a fee-for-service manner. It is challenging to get insurance to cover this because, of course, you get the usual responses that you would expect about, well, why can't you just adopt or surrogacy? And there's many ethical and legal reasons why people would choose to have a uterus transplant over, alternative means of family building. And we should respect, each person's choice for what makes sense for them. But certainly affordability is definitely an issue. But I think this is a challenge that VCA faces in general, whether you're talking about an arm transplant or a uterus transplant, that it's, perhaps not deemed life-saving in the same way that like a liver transplant is, or a heart transplant or a kidney transplant, but that doesn't mean it's any less valuable to the recipients, but you're having to make that argument to convince the bean counters, not physicians who care for patients and really see, how these transplants can transform their lives in very positive ways.
Yes. And through AST, say there's individuals that we want to refer to be able to get to a center. You had this beautiful map that showed which centers are conducting this across the United States. And so I'm curious if maybe we have resources, or we could look into this for AST, where we can see contacts when we have patients who want to get referred and get connected.
Yeah, I think that would be an awesome suggestion for the VCA Advisory Council to add that to their page. I know that there's, obviously a program at Baylor, at Penn, at Cleveland Clinic, at UAB. So not necessarily right next door, but there are many programs that, are up and running, and, interested in serving patients. And as you saw, interest is growing. And that was a really nice study done from Dr. O'Neill at Penn showing, that patients for all different reasons facing uterine infertility are interested in uterus transplant.
That's great. And it looks like Dr. O'Neill responded to about the question about C-section. And, not only you're doing this uterus transplant, but it's this neovagina that's actually being constructed that doesn't have the same structural integrity to be able to have a successful vaginal delivery. So that's really helpful. And then she's also commenting that we don't know what the normal labor curve looks like in a uterus transplant patient. So it'd be hard to monitor and determine if they're progressing as expected. Yeah, so that makes sense. And then Deirdre, could you also just comment on the babies and kind of growth measures in these? And is it similar to what you're seeing as far as like APGARs and the size of the babies or NICU stays, things like that? Does it kind of mirror what we see for babies who are born to like kidney transplant recipients, for example?
So much like kidney transplant recipients, as you saw in the first table, most of these babies are born slightly preterm, so that it was 35 weeks on average in the preeclampsia group and 36 weeks on average. So, they are going to be a little smaller. There will be a higher likelihood of a NICU stay, briefly, but I haven't been involved in the, NICU or post baby care at all.
Yeah. Yeah, it sounds like it's, extrapolating from these babies who are born from other organ transplant recipients, they ultimately catch up. So even if they're smaller size at the time of birth, at least so far from the Transplant Pregnancy Registry International, the baby's growth subsequently into toddlerhood and greater seems to mirror that of children born to non-transplant recipients. So hopefully what we would expect from this population as well. So I think we have wrapped up most of our questions. If there's any last questions coming in, but thank you so much, Dr. Sawinski, for sharing this data. And it's really encouraging, and it's encouraging to know that there's so many centers that can do this. And, right now, not covered by insurance, but I think getting our patients who might have the resources to be able to access this and connect to all of these different centers. And thank you again for really impactful work in moving this field forward.
Well, thank you. I'd like to once again thank my collaborators because without them, none of this would have been possible. The Baylor team, the Penn team, the Prague team. And, you know, I think it highlights the importance of collaboration to move science forward, especially when you're dealing with a very small, unique population. But together we can, you know, advance their care and make things safer. And most of all, I'd like to thank the patients who contributed their data and the VCA advisory group.
Thank you. AST would like to thank Dr. Sawinski and Sarkar, the leaders of the AST VCA Advisory Council, and all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. Thank you all again for today's excellent session.